You're at the cutting edge of cardiovascular sciences. I'm your host, John Cooke. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist Hospital. And we have a great show planned for you today. We're going to be talking about peripheral arterial disease in just a moment. But let me just say a word about our upcoming meeting in May 22nd to 25. Our cardiovascular biomedical engineering meeting is going to be taking place here in Houston. We got the best cardiovascular scientists and cardiovascular regeneration coming to join us. Victor Zhao, National Academy of Medicine, Joe Wu at Stanford, who's the president of the American Heart Association, and Joe Hill, who's the editor-in-chief of Circulation, along with program officers from NIH and ARPA-H and NASA, and we got the best cardiovascular scientists in the world speaking. It's going to be a wonderful meeting, May 22nd to 25, and please take a look at the website and sign up, register. I think it's going to be oversubscribed, so register soon for that meeting. Well, we have another great talk planned for you here today. Dr. Li Lai, who is a faculty member in the Department of Cardiovascular Sciences, is going to introduce our guest.
Thank you, Dr. Cooke. And thank you for the opportunity to introduce our great speaker. Dr. Luke Brewster is a vascular surgeon scientist and a tenured associate professor at Emory University in the Department of Surgery. He's a section chief of vascular surgery at Joseph Maxwell, Cleland, Atlanta VA Medical Center. He got his medical degree from St. Louis University and a PhD in the cell biology at Loyola, Chicago. And he joined Emory University for his vascular fellowship in 2009 and become faculty there in 2011. So he's a current president of the International Society of Applied Cardiovascular Biology and the vice chair of the Peripheral Vascular Disease Council of American Heart Association. Dr. Brewster has received a steady stream of varied federal, foundation, and industry grants. His laboratory focuses on the investigation of the biomechanical mechanism that contribute to the pathological vascular remodeling in the peripheral artery disease. And he develops regenerative strategies for use in ischemic tissue and works to improve the function of the patient that suffers from major amputation. Thank you again, Dr. Brewster, for joining us and looking forward to your talk.
Welcome, Luke.
It's a real privilege. Thank you both very much, and thank you for the nice introduction, Dr. Lee. It's been fun to hear kind of your directions, and it's a privilege for me to get to share some of my perspectives on peripheral arterial disease, as well as some exciting clinical opportunities.
We're looking forward to hearing what you have to say, Dr. Brewster. I want to let our audience know that they have the opportunity to send in questions, and the way they can do that is they can just text DeBakey to 37607. So dial 37607, text DeBakey, DEBAKEY, and then text in your message. We'll get that, and we can ask Dr. Brewster the question, or you can join us by web. Go to polev.com. Enter DeBakey and respond to that activity with your question, and we'll ask Dr. Brewster the question. Dr. Brewster, it's all yours.
Thank you so much. So I wanted to speak a little bit about the muscular dialogue as it relates to vascular health. I think this is something that is really a challenging opportunity for us all. And hopefully I'll be able to share some things that we haven't been discussed as often as other things, and hear your all's thoughts on how we can do this better. So I have no disclosures. This is a slide I stole from Alan Hirsch, who is a good friend, and I thought it was just nicely presents the disease of peripheral arterial disease. It's a broad term. Much like cancer, in that there are many different kinds of peripheral arterial disease, and some are more pathologic than others in a similar manner as cancer. It is defined by abnormal ankle brachial indices, and we'll talk a little bit about that in a minute. But the impact on life in its kind of most or least virulent form, where you have exertional leg pain or intermittent claudication, is housed right between congestive heart failure and chronic lung disease, which are two very morbid diseases. So it really has a profound impact on patients. It has some very interesting mechanics, as you can imagine. Femoral arteries and more distal are muscular, so they have very different mechanics than the more commonly evaluated elastic arteries. And then the flow patterns are obviously disrupted. And as we know, arteries are the dog of the household. They're not terribly intelligent, so the blood will flow in the direction that pressure drives it. And so blood will flow around in kind of varied patterns and around the circuitry and go back and forth and have oscillation, as well as the upstream flow, and then back down will have a low shear, all of which is quite inflammatory. And then it has a worldwide prevalence. So as we do globalize, I think it only becomes more obvious how much peripheral arterial disease impacts patients. It's the third most common atherosclerotic bed in our body, and atherosclerosis is probably only around 40% of the infrainguinal peripheral arterial disease. So it has some very interesting components that make it interesting. I have the privilege of working part-time in our veterans hospital. As we know, our veterans were given cigarettes as they were shipped off for duty, and have a lot of comorbidities, including diabetes. They also are aged compared to a standard healthcare population. And this slide just brings out how skewed it is to the older population. And peripheral arterial disease is strongly driven by age. And that is a reason why the VA is such an important place for the care of this disease, but also discovery. This is a slide looking at the impact of different diseases. And what I'd like to show is that the cardiovascular diseases and diabetes have really increased longevity. This data is prior to the pandemic, where we know a lot of people had a lot of people with the diabetes and cardiovascular disease had increased mortality. But my guess is that it will come back to pretty similar levels in the coming years. So it just shows that the patients with the diseases that lead to PAD are living longer. I appreciate Dr. Cooke and several out there who will have MD PhDs, but I think it's always important to show people that MD PhDs do make a clinical impact every once in a while. I think Dr. Cooke does that often, but Dr. Jimmy Yao recently died, and he was a vascular surgeon. Like many people who enter this country, he was trained in a different country, came over here, and then we trained him again. In so doing, he actually taught us quite a bit. And he went on to be the chair of vascular at Northwestern University. But he's thought of as the person that brought the ankle brachial index to patient care, and showing how it nicely delineates different levels of care based on the pressures. We now know, of course, that calcific arterial disease, or Monkenberg's arteriosclerosis, also brings about a whole new set of ravaging disease, but he was instrumental in us understanding PAD and how it delineates with some disease severity. So I'd like to talk just briefly on the purpose of these arteries. I don't think that we do this often. It is a fun teaser on rounds. But conduits tend to be highways. So if we kind of bring blood out of the aortic valve around the arch and down the descending into the abdomen, and then we bring it past the mesenteric vessels, the renal arteries, and into the common iliac arteries. We have a highway system that is the common femoral artery, superficial femoral artery, popliteal artery, and our 3 tibial arteries into the foot. And the 3rd tibial artery sends branches into the 2 arteries that continue into the foot. And the idea is that these things all work in continuity and bring blood flow. But as we know, the disease will come on in different ways. We often speak of inflow disease affecting the common femoral on up to the aortic bifurcation, whereas outflow will be coming down into the superficial femoral artery or the profunda artery. And these arteries are quite different. So the superficial femoral is the conduit to the foot, whereas the profunda is more of a country road, but terribly important to the perfusion vessels. If we do bypass surgery or stenting, oftentimes we take away the blood flow in between the 2 levels and just have the end game. And as you can imagine, with those kind of bridges, you can have zones of ischemia despite a good pulse or ABI in the patient. The perfusion, as we can imagine, are more the perforating vessels. Again, these can be really important in blood flow when you have blockages, as the blood flow will go through different pressures. And if we think of the leg muscles in our body, they take up about 60 to 70% of our total musculature. So they have a huge and outsized impact on our body as far as the muscular health goes. And then the legs, the blood flow varies according to the needs. And if we are exercising, you could take somebody with a reasonably normal ABI and drop it down quite low. And that's typically seen in people with inflow disease. But the needs of the body can truly change what the muscle experiences. And these muscles can starve in ways very similar to stable angina or unstable angina. And the way we frame these is that stable angina is more like exertional leg pain or claudication, and unstable angina more like chronic limb-threatening ischemia, where there's not enough perfusion to meet the resting tissue demands. So we know some things. I just want to go through them. Optimal medical therapy works. Jair Chung was the first person to identify this. Subsequently, a number of people used the large databases to demonstrate this. But if you have people on the right medicines, they're much less likely to undergo major amputation. And Jair's a neighbor of your all down there in Houston. And then lifestyle modification works. We know that walking therapies will increase walking distance, and that smoking cessation changes everything with people. So if we do put these together, we know that goal-directed medical therapy is really great for peripheral arterial disease patients, and those folks will do well and have a low incidence of major amputation if they follow that guidance, as long as they are in the either asymptomatic or exertional leg pain groups. And finally, if we do intervene on people, the recidivism of a wound is much lower than their mortality rate. So once you get a wound healed, you really do save the leg and you save the life of these patients. But the contra view of this is that these people die of cardiovascular disease. Most commonly, second is cancer. So, and these folks, when we do revascularize them, we know that the outcomes of that will be better the first time than the second time, and that's been shown in multiple studies, both endovascular and open surgery. So this is a patient of mine in the upper corner, and he was a tough hombre and lived with PAD and had exertional leg pain. Did not require future revascularization. He had 2 operations, both of which failed. But he wrote a letter to me once talking about walking a mile in his shoe and the pain that he had on a daily basis. And when we think about that, this is something that we really haven't learned how to treat. Even with revascularization, pain is often refractory to the improved ABI. And pain is a systemic disease, often mediated, in our opinion, from the skeletal health. And if we take a look at the bottom corner slide, you see just how robust the vasculature is in defining the muscle groups that we see. So they are intimately related. And if you look in the top slide, looking at a more diseased with the asterisk and less diseased with the pound sign, and just a representative slide of fibrofatty degeneration and PAD, you see quite obviously that the muscle is profoundly affected by ischemic disease. And this can be even in asymptomatic patients. We took the perspective that the myoglobin in the muscle is a good thing, but when it spills out of the muscle, it's a harbinger of muscle death and injury. And we compared this in control patients, people with exertional leg pain, and people with chronic limb-threatening ischemia. And we saw, pardon me, a significant stage-like increase in the myoglobin with advancing disease. Interestingly, the nitric oxide availability decreases obversely, and the fit of the curve fits nicely in that those two important mediators of disease appear to be linked inversely. We have developed a large animal model of ischemic myopathy that pigs, as we can see here, are not humans. A human would not have the common iliac coming out of the middle. The common iliac would come off the bifurcation instead of a trifurcation. But we've taken advantage of this in the pig to induce a claudication model where we knock out the external iliac of the pig and you get reconstitution at the femoral level. So a one-level disease, much like superficial femoral artery disease. And we can get ischemic myopathy. And the most importantly, we have sustained ischemia, which is important as a lot of animals will come back with reperfusion through collateralization and arteriogenesis almost in real time. And this work was done in part by Dr. Long, who's now at Duke as a director of their vascular program. And when we look at the different muscle groups and the myopathic scores, these are increased in our model. So we think we have something workable that can tie together the muscle disease that we want. I had the benefit of attending during the pandemic one of our Department of Medicine research days. And here we had Dr. Gladwin, and Dr. Gladwin was talking about the free hemoglobin and its impact during sickle cell crisis. And this got us to thinking that myoglobin and hemoglobin have a lot of similarities. So perhaps the same pathologies that are seen in sickle cell disease, particularly crisis, may be applicable to patients with PAD spilling myoglobin. We took healthy mouse arteries or aortas and exposed them to increasing doses of myoglobin and saw that they had increased contraction and tone that continued to go up with higher levels of the myoglobin. And this was significant versus untreated at all dosings. We then made our pig model more severe by disrupting the blood flow bilaterally to the external iliac and then knocking out the inline perfusion to the internal iliac on the right. So 3 of the 4 inflow vessels to the animal were occluded. And what we found is that we had a profound low ABI that then came back up to about what we see in the other model. It's a little bit lower here at 0.35 as opposed to 0.6. That we have sustained oxygen debt in this model, that the myoglobin goes up in these animals when we exercise them on the treadmill. Here we have Dr. Hoffman who's a Houston native and a PGY4 interviewing for vascular surgery now, who was in the lab doing this. And then if we look at the flow-mediated dilation as a surrogate of endothelial cell dysfunction, we see that it becomes abnormal post-exercise. So we wanted to look at our patients again, and what we did is we characterized the likelihood of, or the absolute event rate of death related to myoglobin, and we found the asymptote somewhere around 100 nanograms per ml, where this really increased. And interestingly, we actually had a longer follow-up in the lower myoglobin patients. And from this, we took home that the myoglobin increases tone, and that tone may be related to vascular disease. And we also took to it that the myoglobin may act as a nitric oxide sink, and that sink may decrease the bioavailability of nitric oxide and have an impact on cardiovascular events. And this is just an overview of kind of that interaction that we see between the arteries and the muscle. And we published this last year in Journal of American College of Surgeons. So our future directions are to look prospectively at the role of myoglobin in endothelial dysfunction, optimize regenerative therapies, as that's another direction of our lab, to build muscle under ischemic conditions, and then better define the role of rehabilitation and revascularization in vascular health. We have some contrasting ideas, and Robert Fitzgerald said that if you hold two contrasting ideas in your head, you might learn something. And so with rehabilitation, walking is good, but perhaps myoglobin spillage may not be as good and may actually be harmful. And similarly, in revascularization, we can certainly improve the blood flow going south, but how do we improve the blood flow to the muscle? And how do we tune these conduits to improve the perfusion? That continues to be a challenge for interventionalists and surgeons alike. And then finally, we know that, for most patients, if you're asymptomatic or if you have exertional leg pain, that you really benefit from having nothing done, as far as you're more likely to keep your leg and prevent acute limb ischemia without intervention. And as we try and balance this with improving the muscle health, it's going to require some nuanced testing as well as more robust clinical trialing in this space. So I'm a fast talker and have plenty of slides that I can share with questions as they come up. But I wanted to share a little bit of our team. And we are very proud of the folks that we work with. Yasin Doueri is our acting chief of vascular surgery, Dr. Guillermo Escobar, Dr. Badr Nathan, Dr. Mahajan, all at Emory. Dr. Alabi, Dr. Heckman, and myself are at the VA as well as at Emory. And then at our Veterans Hospital, we are one service integrated with Emory and Morehouse, Drs. Henry and Brathwaite here. I'm very proud to say that all four of us have federal funding, and Dr. Henry helps with one of our clinical trials that's funded through the VA. And then these are some of the trainees that have helped in this work. With that, I'd show my funding and a little plug. After you go to Houston in May 22nd to 25th, please consider coming to Vienna for the ISACB annual meeting. It'll be a great integration of similar ideas and focus on translation, and has a lot of clinicians as well as bioengineers and vascular biologists. This is our team from the lab. Dennis Foster is a surgery resident. Michael Teachman runs the lab from the VA. Miss Gloriani Sanchez Marrero is a bioengineering graduate student at Georgia Tech. And Fuji Zhao is a really talented junior scientist who is immensely helpful to us. So with that, I'd just like to say that revascularization with X-ray or with sewing can help, but we're going to need better research to close the gap between the vessels and the muscles. And it's been a privilege to share these thoughts with you, and look forward to any questions. Thank you.
Well, thank you, Dr. Brewster, for an outstanding presentation and some really intriguing ideas. We're going to have a little discussion now with Dr. Brewster, and I just want to remind our audience that they can send us questions. Just text DeBakey to 37607, so dial 37607 and put in DeBakey, D-E-B-A-K-E-Y, and then text us your message. Or you can go to polev.com if you're online, joining by the web, and enter DeBakey, D-E-B-A-K-E-Y, and send us your question. Well, I really enjoyed that, and I learned a few things. Luke, thank you. I wasn't aware of this interaction between circulating myoglobin and mortality in patients with peripheral arterial disease. So I guess your hypothesis here is that with exercise, the ischemic muscle is becoming strained, maybe damaged, and releasing myoglobin into the bloodstream and maybe having systemic effects. Is that correct?
Yes. Dr. Annex had shown before that you really needed that stress to get the angiogenesis. And we were looking for biomarkers of PAD that might help explain why patients with peripheral arterial disease and otherwise the same as somebody else, why they had such an increase in their mortality. It's 2 to 3 times higher for both events and cardiovascular cause of mortality. And after I heard Dr. Gladwin talk, I called up some friends and we put together our patient samples, and we're able to show that it is correlated. Now, we have not definitively proven that this is a cause, but I think it's a very likely contributor to an increased tone, which, if you see the 65-year-old otherwise healthy marathoners often are these type A people that will have those increased tone. But I think even more so, likely the capture and removal from the system of nitric oxide likely puts people at a greater risk of having an event or a significant event when you have an adverse clot or progressive stenosis.
Yeah, that makes a lot of sense to me, that the circulating myoglobin could have a detrimental effect systemically. I believe Robert Furch got the Nobel laureate for the discovery of nitric oxide. One of his proofs that the endothelium-derived relaxing factor was nitric oxide was the finding that myoglobin, or heme, could inhibit this endothelium-derived relaxing factor, which was nitric oxide. It was one of his proofs, that nitric oxide.
Yeah, it's come around circle. I think it was intuitive in sickle cell, but I think it's something that, is a very treatable idea if it's found to have these effects in a prospective manner.
Now, whereas you mentioned Brian Annex, who's the great endothelial biologist and clinician who takes care of patients with peripheral arterial disease, mainly from the endovascular side, angioplasty and such. Well, you mentioned that he showed that in his animal models that you needed some ischemia to induce angiogenesis. But I mean, with taking that into consideration with your findings, maybe there's a Goldilocks zone for inducing ischemia by walking. I mean, we tell people to walk, but maybe there's, you can overdo it if you're damaging the skeletal muscle and releasing myoglobin. Is that fair to say?
Yeah, I think that's likely true. I was talking to Dr. Lee beforehand about Heracles Pepinos, and he has some very interesting data in patients that are responders and non-responders, both to walking therapy as well as revascularization. And there are just some differences that exist. And so I think tuning the therapy to the patient is going to be key. And I do believe that there is a Goldilocks, but it's not obvious to me what that will be. Dr. Mary McDermott's studies suggest that less rigorous exercise has less benefits in the absolute walking ability and slowing down the decrease in 6-minute walk test over time. But there have been some Scandinavian rehabilitation folks who suggest walking to pain and not through pain helps with compliance. And I think one of the fun things with our pig model is that we really can control all of this on the treadmill. And we may be able to help optimize not only the walking strategies, but also how best to minimize myoglobin spillage.
Could you use myoglobin as a biomarker to kind of tune the walking regimen for these patients? I mean, walking is really good for patients with peripheral arterial disease, but as you mentioned, I mean, too much walking can cause myoglobin release and have adverse systemic effects. Maybe myoglobin is a biomarker for?
Absolutely. Yeah, that's one of our directions that we're doing. The challenge, of course, is that a lot of the kind of point of care measurement tools get confused by the hemoglobin as the overlap is there. But I think with some of these really smart people that you'll have in May at your place, I'm sure lots of people would have good ideas. We've been working on a biosensor with some folks at Georgia Tech and just need to better tune the ability to find that myoglobin.
You know, I was just thinking it might be an opportunity for you and your group if you develop such a biosensor. I mean, to commercialize that, it could be very useful for our patients with peripheral arterial disease. You know, it also could be useful for guys like me that weekend athletes that go out and run. How far can I go before I start causing damage? That'd be an interesting biomarker. I think could be useful for anyone over the age of 60.
And yeah, we're all following our steps and we're following everything else.
Right.
And an ounce of prevention can be better than a pound of cure.
Yeah, the American Heart Association is going to change their recommendation. It's not going to be X steps. It's going to be X steps depending upon your myoglobin marker. Yeah.
maybe, or just as you can imagine, myoglobin could also be a surrogate for pain, because we know muscle death is a cause of pain. So this idea of pain-free exercise, I often will challenge patients with ideas on recumbent bike or walking in water. On using these tools, and oftentimes the exercise will get a similar amount of muscle engagement, but not have as much of the pain associated with it. And so such ideas, I think, are very likely to be useful in this manner as well.
Wow, really interesting. I'm going to turn to my faculty member, Dr. Lee Lai. Dr. Lai has done some really nice work in a model of peripheral arterial disease, which is murine hind limb ischemia. You probably know this one where you tie off the femoral artery. It's a good model for muscle ischemia, maybe not for peripheral arterial disease, but a good one for muscle ischemia. But she's found some really interesting results that may have relevance to our patients.
Yes.
And in fact, you got some data that from our patients that are consistent with your hypothesis about cell fate transition and ischemia.
Yes. So I think I'm just gonna ask Dr. Brewster about this question, because he's using pig model. So for us, it's not that practical for us to just use pig to study this disease. And we are using this high-limit ischemia model, but later on I'm going to ask your opinion about this model. But what we found with this model is we found during the revascularization after the femoral artery ligation, there is a glycolytic shift, which is essential for the fibroblast cells within muscle to open chromatin and become more plastic to become another cell type. In our case, our hypothesis is there are a small portion of the fibroblast cells. They can become endothelial cells, and those endothelial cells can eventually contribute to the revascularization during the recovery. So that's what we found, and we want to identify these identify the markers for these fibroblast cells that are able to convert to endothelial cells, and then we enhance this process to enhance the revascularization. So that's what we found, and we found some metabolic signatures of those of this process, and we are working on validate and trying to enhance this conversion. But my question is, what is your thoughts about a good model of the peripheral artery disease for us to study this disease? So especially small animal model.
Yeah, but there's huge benefits in small animals, and we use them as well. And we can ask a lot of specific questions, and like the question that you're asking, I think is wonderful because of the knockout technologies, but also the accessibility of these muscles. There's a lot of beauty in the murine hind limb ischemia model, in that depending on the strain you use, you can have a natural history of recovery that's quite nice and replicated in many ways in young patients. We have little babies that we care for, and they get a femoral artery occlusion from a procedure or intervention, and you see almost in real time the collateralization and overcoming that in these little children. And I think that all these models can be super useful for certain things. I'm a old folk music person, so Steve Goodman had a song about men who love women who love men. And I think what we're finding in our cells, particularly with lineage tracing, is that there's a lot of fluidity, and it's contextual. And the more we can stimulate endothelial cells from nowhere to come into existence, they will find a way to inosculate. And as I said, arteries are dogs. They're faithful, but they may not be smart, and they'll run that blood this way or that way depending on the pressures. And so I think that such ideas are really important. Using tissue that's already there is a super exciting idea. We have looked at this to some degree in the adipose mesenchymal stromal cells, and looked at these cells closer to the deep tissue, which is the nerve, which is relatively preserved in these conditions, particularly the chronic limb-threatening ischemia. And they too will have an increased endothelial cell marker component. So I think it's a very real thing, and it takes a beginning to make a big construction project. And I think that this is a great idea for delivering blood flow. And you just have to figure out kind of how to put those train tracks together, because they have to go north and south to a reasonable size collateral, and they also have to go east and west to get to the skin to really have the adequate perfusion. So it's a big task at hand that we ask of these regenerative technologies, but these are the days, and the tools that we have nowadays I think are amazing. And we also have, as you know, the FAPs, or the fibroblast kind of adipogenic precursors that help protect the satellite cells, and those are exceptionally bioactive as well in the regenerative process. So, when we start studying one thing, we really end up studying a whole universe.
That's fascinating. You said something really, I thought, very interesting and true, is that in humans and in our mammal models, there is a lot of plasticity in response to an injury. In fact, that plasticity is absolutely critical for wound healing, for a response to an injury. And what we found is that an inflammatory event or a hypoxic event can have a dramatic epigenetic alteration. Cells, we're studying our fibroblasts, and in the fibroblasts, the chromatin opens up, and now those fibroblasts are able to transition into a different cell fate depending upon the milieu, what kind of signals they're getting. And the signals we've been giving those fibroblasts are signals to become endothelial cells, and we do see this transition in vitro, and now my young scientists, Lily among them, have shown that this process occurs in vivo in our animal model of peripheral arterial disease. We call the process, we call it angiogenic transdifferentiation, the transdifferentiation of fibroblasts to endothelial cells, and it appears to play an important role in the recovery from ischemia. Because when we block that process, we get an impairment in limb perfusion. So it's a whole new angiogenic process that's occurring.
No, it's very important, and I think the more connections we make, the better the collateral vessels do, and if the collateral vessels have more outputs, they'll grow, and it takes both. It takes new vessels and existing vessels to improve the situation.
I was going to ask you about the adipogenic, or the fibrous adipogenic transition that occurs. And I was wondering, in fact, if that, if our transdifferentiation phenomenon, that plasticity that's induced by ischemia, if that is playing a role. Do you think it's a cell fate transition that's causing the adipogenic replacement of muscle tissue? Is it a transition of fibroblasts to adipocytes, or is it, where are those adipocytes coming from, I guess is the question.
Yeah, my guess is from a number of places, but I think it's largely a loss of muscle fiber. So these are actually being replaced, and whether the cells have a fibroblast origin, myofibroblast, or if these FAPs just get fed up and decide to go the other way, which they can do, it can totally take away from the muscular architecture. One of the ways that we look at this is a very primitive way. When people do undergo major amputations, their muscle, when you put a flap over, you've disconnected the tendons, so you've disconnected the tension that is required to make a muscle. And so the fibrofatty degeneration of the remnant limb occurs all by itself in that de-stressed event. You also have, as we know, in peripheral arterial disease, the denervation of those muscle, and that by itself will do the same thing functionally as taking away the strain, because it won't have the tone. And the muscle's natural slumber or hibernating mode is towards a more adipose tissue.
Interesting. I'd like to turn toward translation. You're a scientist and a clinician. You
Yes.
have a MD and a PhD. You're a vascular surgeon who's trying to understand the mechanisms of vascular disease. And as a clinician, you must want to see your insights get translated into something that's going to be useful to patients. Tell us about that process, how you consider it, the translation of your ideas. What steps are you taking to take those ideas, to the bedside, to commercialization?
Like you all, I'm trying to follow in your footprints. Using human tissue, studying important problems, and then involving the patients in the research. The generosity of patients in their tissue, in their participation in clinical trials, in their participation in survey instruments and other things to try and identify what things are most important to them so that we don't solve the problem that we feel is most important, but the one that they feel is most important. I think that those are the really important tenets of a clinician scientist. As a surgeon, we do work, on a daily basis with clinicians, as our patients will call us or come in, even if we're not on doc of the day duties. And that helps keep you tuned to their problems. And then, again, very similar to you and Dr. Lai, having the next generation of scientists and physician scientists that we get to train. We have a pathway at Emory for a surgeon scientist in our vascular residency. So they come out after the second year and spend 2 years with one of the researchers in our group, Dr. Alabi, Dr. Heckman, Dr. Brathwaite, or myself. And, we really get that time with them. I think the greatest failure for any of us is not the lack of translation, but the lack of betterment, that the next person who comes after us is better than we were. And I like to keep that in mind because clinical translation can be humbling. But again, if you keep attacking important ideas, you have some chance. And then engagement of the tech transfer offices, both at the university as well as at the Veterans Affairs. We have pretty close relations to those folks, and try and work with them on things that are commercializable. Mm-hmm. Pardon me for English as my first and second language, but still have some challenges.
That sounds pretty good. Do you have, how much assistance do you get from your university, the Office of Technology Licensing there? Are there, tell us a little bit about that, about how they help you translate.
So the initial disclosure is pretty easy. So we fill out a form before we publish or present new ideas that have the technology entwined in it. And then they run the prior art. And that's all done both at the university or at the Veterans affiliate. And from there, then you kind of get some go, no go, and possibly some other work. As I'm sure you've experienced, sometimes the prior art doesn't appear to be very similar, but appealing it may not be that cost effective. So sometimes things fall apart at that level. Obviously, advocating and investing in your ideas is the key. Nobody's going to believe in it more than you will. And so trying to keep that as whole as possible as long as it can is really good. We're pretty privileged at Emory. Rebecca Levitt's a cardiology investigator, and she's had a number of successes in getting things licensed and companies formed. So while she's my junior at the hospital, she's my senior and one of the people I go to for advice, as well as Bob Taylor's really great. And then we've had some successes in our Department of Surgery, particularly around transplant immunology as we've developed some medications along those lines that have been useful. And then whenever I give my PhD lecture to the medical students, I like to share with them some things about vascular that I think are pretty cool. And one of them is that we, give drugs that are magic. I don't think we really understand how statins work, at least not in a holistic way. So I like to say that those are magic. And then there's a number of vascular surgeons that own wineries from their developments. So I say if you want to use magic and possibly own a winery, vascular might be for you.
Funny. I'm going to let Dr. Lai ask the last question.
I think my last question is, can you tell us a little bit more about what's the sex difference in PAD?
Sure. I think that this is going to be, again, one of these individualized opportunities. Where I see the greatest opportunity is that women tend to lag behind men in developing PAD until about somewhere between age 60 and 70, and then the women really shoot up and catch up with the men into the 80th and surpass them. And so, sex, hormone, and then just vascular differences, I think, are very real. We've seen in a number of the rodent models that something similar does happen. Of course, the rodents don't naturally undergo menopause, but with some of the tools, we've been collaborating or beginning a collaboration with Bernard Ogola out of Augusta in Georgia. And, there's these animal models where you can have the sex chromosomes disconnected from the sex hormones and really get to see some of these things. One of the most profound biologic differences that we found have been in the responsiveness of female endothelial cells to changes in stiffness and flow. And I believe there was a publication, and forgive me for not having it in my brain, that looked at YAP-TAZ in differing laminar shears, and they used human umbilical vein endothelial cells. Mm-hmm. And they saw that the female donors were less responsive to shear. I think that these kind of things, and how would this change in an older person or in a person who's postmenopausal, there must be something going on that has a mechanical switch to lead to that progressive stiffening that really outpaces men as women age. And, we still have a delta of somewhere between 2 and 5 years for women. So the fact that it happens later is a great biological consequence because most of the women are still alive at those ages.
Well, thank you, Dr. Brewster, for a wonderful presentation. And I really, really enjoyed talking to you about peripheral arterial disease. And furthermore, I hope to hear more about the myoglobin story. I think that's really interesting. And I hope that you can develop that toward a tool that we can all use to maybe fine-tune our walking programs for patients with peripheral arterial disease and our exercise programs for weekend warriors.
Well, thank you to you, Dr. Cooke, and to Dr. Lai. It's been a real privilege, and I'm super appreciative of this opportunity.
And we'll be back in touch with you. We're looking forward to collaborating with you a little bit.
It'll be a lot of fun.
Yeah, it will. It sure will be. Well, thanks again, and thank you all for joining us at the cutting edge of cardiovascular sciences. Our guest today was Dr. Luke Brewster, who's a well-known vascular surgeon at Emory, who gave us a wonderful presentation today about peripheral arterial disease. Thanks again, Dr. Brewster.
Thank you. Have a great day.